Hey guys, very good evening. Can you hear me? Can you see me? If so, say me a hi and a hello. So we are in the second part of tumor suppressor genes. Yesterday we saw quite a good number of tumor suppressor genes. We saw the basic concepts of tumor suppressor gene, and also we saw about P53, right? Today in the part 2 of the lecture of tumor suppressor genes. Hello Rahul, very good evening. I'm going to talk about retinoblastoma, a gene called as CDH1 and a gene called as STK11. This gene particularly we didn't read in the essentials batch. We will read definitely in the essentials batch sometimes later, but I just wanted to change the little bit of genes whatever we read from it. I'll add on to whatever is required for you in the essentials batch for sure, right? Good evening, Pratna. So without any delay, let's go. And before going, I need a few information from you guys. Let's see if all of us are in the same path. Tumor suppressor genes, you will have gain of function mutation or loss of function mutation. That's the first question. I want you guys to comment on it. Second, a tumor suppressor gene, you will have one allele loss or two allele loss. What will be the number of alleles lost or mutated in case of a tumor suppressor gene? Wait, tumor suppressor gene will have loss of function mutation and you'll have a biallelic loss. It will always be two alleles loss, not a one allele loss, right? Okay. Now let's go to understanding like what happens in your retinoblastoma gene, the normal function and how it causes cancer. The same with a normal function of CDH1 and how it causes cancer, and same with STK11, right? So retinoblastoma is also dubbed as a governor of cell proliferation or cell division. Okay, they govern the entire cell proliferation. That's what retinoblastoma primarily does. Let's see what's the normal function of retinoblastoma. Anyone tell me what are the phases of cell cycle? You must have read about cell cycle, right? So let's draw a cycle. Not a good cycle, but it's fine. So the phase of cell cycle, if you know that, you will have G0. G0 is the resting phase. You'll ignore that. We have G1, we have S, we have G2, and we have M, right? So G0 is a resting phase, or G0 is a resting phase, right? So between this G1 and S, I have a cell cycle checkpoint, and between G2 and M, I have one more cell cycle checkpoint. Fine. Yes, Medico, I'm here. So what happens is, when I have cell cycle checkpoints, the purpose of the cell cycle checkpoint is to stop the cell cycle at that point. Good evening, Shalini. Right? And if there is any error, to correct them. And the guy retinoblastoma sits exactly in your G1S. So the retinoblastoma function is very simple and very specified. They will stop the cell cycle at G1S. So the retinoblastoma is active. If it's an active, it's in a hypophosphorylated state. Okay, it's not having good amount of phosphorylation, it's active, and it's active, it closes the G1S gate. So no cell can move from a G1 to S if the retinoblastoma is active. Clear? Perfect. Now if a cell has to move from G1 to S, what should I do to retinoblastoma? I should be making them active or inactive? So obviously they should be made inactive, right? So if I'm making it inactive, I need to inactivate it, and the inactivation is only by one means. We'll learn about them very soon. If RB genes becomes inactive, it's not functioning, right? So it will be by phosphorylation. I need to add a phosphorylation group, right? When there's a phosphorylation, it becomes inactive, and this will open the G1S gate. It completely opens your G1S gate. This is what happens here. Perfect. No medicos in Uzbekistan. Retinoblastoma is a gene, right? RB is a gene, and the gene will produce a protein product. That protein is the one, like we have multiple genes in our body, right? Like that I have an RB gene, retinoblastoma gene, which is there inside every cell, which produces a product which will block the cell cycle. Fine, I hope it's clear. So for me to make it inactive, I need to phosphorylate it. The way to phosphorylate here, hello Lalit. So the way to phosphorylate here is by enzyme called as kinases. So I have few enzymes called as cyclins. If you remember our first class in Robbins, we saw about cell cycle, right? So I have cyclins, and then I have cyclin dependent kinases. So whenever I have cyclins and cyclin dependent kinases, that will activate or inactivate the retinoblastoma so that a cell can move from G1 to S phase. So I have a question here. I want everyone online to answer this. Lalit, Medicos, Prarna, Shalini, whoever is online. So tell me, if kinases is going to push a cell from G1 to S phase, it's a tumor suppressor gene or a proto-oncogene? It's going to support cell division or oppose cell division? It will support cell division, right? So it's a proto-oncogene. Perfect. And retinoblastoma is a tumor suppressor gene. Like we read before itself, always a proto-oncogene will always be combined with the tumor suppressor gene. This is a proto-oncogene because that activates support cell division, and RB is a tumor suppressor gene, right? Perfect medicos, perfect. Okay, so one is proto-oncogene, one is tumor suppressor gene, fine. And every tumor suppressor gene will have gain of function mutation or loss of function mutation. Let's assume if RB is getting mutated, RB mutation or retinoblastoma gene mutation is always a, just now we saw, it's always an LOF stands for loss of function mutation, right? So when I have loss of function, which means RB is inactive, right? RB is definitely inactive. Okay, perfect. Then when I have an inactive retinoblastoma, so the cell cycle, the G1S gate will be open or closed. If RB is inactive, G1S will be open or it will be closed? It will be open, right? Because if you remember, this is what we saw. Whenever RB is inactive, that's an hyperphosphorylated form, it always opens the G1 case, right? So whenever RB is inactive, due to a mutation, it will always make the gate G1S open. Okay? Mutation is permanent or temporary? It will open, right? Because it's inactivating, it's loss of function. When it's active, it closes. When it's inactive, it opens. I hope it's clear, Lalit and medicos, fine. So here mutation is permanent, right? So it opens the G1S gates permanently. I won't require any cell cycle growth factor. It's always open. So cell division will become more or less. Every cell from G1 moves to S. If it moves to S, S stands for synthesis phase. So more cell division, less cell division. Obviously it will result in very high amount of cell division. Whenever I have a very high cell division, obviously it's going to result in a cancer. Excess cell division will obviously result in cancer or neoplasia formation, right? That's how retinoblastoma causes cancers. The next question is, in what all ways by which I can have a retinoblastoma mutation? We understood that yes, definitely, only when it is mutated, I'm going to have a cancer. If it is normal, it's completely normal. It does its job, right? So RB gene mutation can happen in two types. One, congenital. I have a problem congenitally at birth. I have congenital retinoblastoma syndrome. So where there's one loss at birth. When the kid is born, there's no retinoblastoma at all. So this, you'll have increase in risk of retinoblastoma, which is a tumor in the retina, okay, tumor in the eyeball. And then I have one more problem, osteosarcomas. These kids also have a very high incidence of osteosarcoma, fine. Doesn't matter, Lalit. If there is a mutation in the tumor suppressor gene, loss of function mutation, whether the proto-oncogene functions or not, it will form a cancer. Let's take your example, Rahul. Let's take your example. In the same example, right? Let's assume my RB gene is having a loss of function mutation here, right? It's lost. Do I need kinase here? It's lost means it's always inactive. Do I need kinase? I don't require this at all, right? I don't require this. It's always inactive because of mutation, so it will definitely cause growth, right? It doesn't matter for me if the tumor suppressor gene or if the proto-oncogene is normal or abnormal, fine. Okay, there are two ways by which a retinoblastoma can get mutated. One is my tumor in the eye, congenital, and also osteosarcoma. Second place where I can have an RB gene mutation is HPV infection. What does HPV stand for? HPV, human papilloma virus, right? So in the human papilloma virus, I have a viral protein. It's a virus. So there is a viral protein in the human papilloma virus, which is termed as E6 protein. Okay, E7. Right? There are two proteins. The one which destroys retinoblastoma is an E7 protein. Right? So this E7 protein of this human papilloma virus will destroy RB or will mutate RB. Okay? So there are two ways I can have a cancer due to retinoblastoma. One, a congenital loss, or something which is acquired due to HPV. HPV has two proteins, E6 and E7. E7 destroys retinoblastoma, E6 will destroy P53. Fine. So that's how HPV causes diseases or cancers. Two ways I can have RB gene mutation. Fine. Okay. So if you are in a second year and if you are asked a short note on retinoblastoma, you need to structure it. First, write the name, governor of cell division. If you want, add to it. It is seen in chromosome 13q14. That's a location of the retinoblastoma. Then you can write about the normal functioning of retinoblastoma. You can put a cell cycle and write it, right? I'll come to it, medicos. Second, you tell that if RB gene is abnormal, if RB gene is mutated, what will happen? The pathogenesis and what all cancers can happen. Then what all conditions I can have an RB gene mutation, fine? Medicos, in the last class, we read about P53. It's also a protein and a gene like retinoblastoma, a loss of function mutation. It's also a tumor suppressor gene, fine? Lalit, once you finish your MBBS, you get into your MD or MS, you can become a MS gynecology, you can become a gynecologist, fine? Next, the second gene of today's question is CDH1. That's the second gene we are going to discuss. Let's assume what a CDH1 gene does. Again, always normal. We need to know normal. If I know normal, abnormality is very, very simple. The normal CDH1 gene produces a protein called as E-cadherin. They produce E-cadherin. Have you heard about E-cadherin in your first year of MBBS? What does E-cadherin do? Rahul, yes, I can definitely pick up oral tumors with P16 mutation. I can do it on biopsy, or with clinical examination you can pick up the Warty things. There are multiple ways to pick up HPV viruses, right? So E-cadherin functions two things. One, you might have read already, they are a classical cell adhesion molecule. Okay? A classical cell adhesion molecule, that's what your E-cadherin does, fine? Along with the cell adhesion molecule, they have one more function also. Let's assume I'm having a cell like this. Have you guys read about desmosomes, hemidesmosomes? The cells which adhere, it's like that, right? So they're going to adhere with each cell. That's what E-cadherin does. So E-cadherin joins these cells. It's the function of E-cadherin. That's one function which is already known. It has one more function in the cell division. Let's assume I'm having cells like these. All these are multiple cells, right? Between each of these cells, you will have an adhesion molecule. That's what E-cadherin is, right? Let's assume in this group of cell, one cell dies. I'm just giving a random example. Let's assume that one cell here dies. I have a cell here, I have a cell here. Okay. So this cell here dies, fine? So if this cell dies here, will the E-cadherin here lost or it will be present? I'm having a dead cell in the center. Will there be a loss of E-cadherin in this part or present? Because there's no one here, so this E-cadherin will be lost, right? So this E-cadherin here will not be present because there's no cell there, it will be lost. So when this loss happens, there is no contact. Whenever there's no contact, automatically cells needs to be replaced and the cell will be replaced, right? So once E-cadherin is present, there is contact with a neighboring cell. Okay, obviously you have a contact with the neighbor cell, which means this will reduce cell division. This is the other function of E-cadherin. So if I have a contact with the neighboring cell, the cells will not divide. That's one function. If there is a cell death and there is loss of contact, tell me what they will do. There's a cell death, a cell dies, and because of a cell's death, there's a loss of contact. It will promote cell division, and the motive is very simple here, in order to replace the dead cells. Okay, that's what my body has to do, right? So whenever an E-cadherin is present, my body knows that, okay, I'm in touch with another guy, so I will not divide, I'll keep quiet. Whenever the contact is lost, whenever the cell dies, contact will be lost. My body knows that, okay, there's no neighboring cell, let me divide and replace them. That's a simple function of E-cadherin. Apart from the cell adhesion molecule, yes, They perfectly do two functions, right? This is what the function of E-cadherin is. So tell me now, when E-cadherin is normal, listen carefully and answer, not in a hurry, take your own time. When E-cadherin is normally present, will the cells divide more or cells divide less? They will divide less. So E-cadherin or your CDH1 gene is a tumor suppressor gene or proto-oncogene, or they promote cell division or they suppress cell division. When E-cadherin is present, medico, what will happen? The cell will not divide. There will be reduction in cell division whenever there's a contact, right? Right? Okay, perfect. So when E-cadherin is lost, the cells divide more. So E-cadherin is or the CDH1 is a tumor suppressor gene. Lalit, squamous cell carcinoma is a tumor of squamous epithelium. I don't understand your question, Rahul. Can you rephrase it, please? Okay, so now let's assume what will happen to when I have CDH1 mutation. So CDH1 is a tumor suppressor gene. Gain of function mutation, loss of function mutation. 100% loss of function mutation, right? So whenever I have a loss of function mutation in CDH1, what happens here is, it's simple. I have a cell here, there's no CDH1. Can they bind to another guy? No. So obviously every cell here will be separate. Now listen carefully and answer to me. Okay, every cell here is separated, right? So is there any neighboring cell here? No. So what will my body do? Will it divide more or divide less? There's no E-cadherin for any of these cells. So the impulse is there's no contact. There's no contact means cells will divide more. So this cells divides again. So it becomes here. Ideally in a normal person, the two new daughter cells will unite. But here they don't unite because again no contact. So it will divide here. When there's no contact again, will it divide again? It will divide again. This will divide again, this will divide again, this will divide again, this will divide again. So the cell division is uncontrolled? Yes. Definitely it's uncontrolled. Every time a new daughter cell comes, there's no contact. My body does things that, okay, there's no neighbor cell, let's proliferate. Again a new cell comes, again no E-cadherin, again no contact, it divides again, right? Understood? So that's how a CDH1 loss will result in an extremely uncontrolled cell division. When cause an uncontrolled cell division, obviously it's going to end up in having a cancer. Okay? Yeah? Perfect. So this is how E-cadherin loss or a CDH1 loss will result in a cancer. Let's understand with the help of one example. So we know the normal function of E-cadherin. We are doing the same template what we did for retinoblastoma. Happy Holy Panda. Second thing, we know what is normal CDH1. We know how it's getting mutated and how they cause cancer. Now, in what all conditions you see cancers with CDH1 loss? There are quite a few cancers. I will name 3 of them. If you remember 2, that's more than enough for me. 1, diffuse gastric carcinoma. You will have an E-cadherin loss. Second, a lobular carcinoma of breast. There are various types of breast cancer. Only lobular carcinoma of breast will have this. Third, just an extra, if you want an extra mark, write this also, esophageal cancers. Okay, all these can have an E-cadherin loss. These 2 never forget. Okay, Rahul, when you talk about tumor cell adhesion, no, let's take squamous cell carcinoma, right? Let's assume this is my bronchus, fine? This is my normal bronchus. Is there any contact this side? It's a lumen, right? Normally also there will be no contact. So when I talk about contact, contact is here. That's the neighboring cell there, right? So anyway, it's a lumen here. The tumor grows like this. There's no contact towards a lumen. Always contact with the neighboring cell. If I have a tissue completely like this, maybe center cell will have contact, but in the epithelium, one side normally also have no contact. That's why normally cells don't grow inside epithelium, fine? Okay. These are 3 cancers where you can have a CDH1 loss. I don't want you to forget this, write them, fine? Okay. So we know mutation of CDH, normal function of CDH, and cancers you can have CDH. CDH1 can also be inherited, and few random things can also cause CDH1 mutation, right? Let's go to one more gene of today's discussion, STK11. Okay. STK11 gene has two functions, same, not exactly like CDH, different two functions. The first function of, again, normal STK11 is to suppress cell division. Obviously, it's a tumor suppressor gene, right? It will definitely suppress cell division. The second function of STK11, what STK11 does is they will maintain polarity. Okay, maintains polarity of specifically GIT, but in general most of the tissue. I'll tell you what exactly polarity means. To understand polarity, just to understand polarity, I want a little bit of help from you guys. Can anyone name the layers of GIT? The layers of GIT, can anyone name that? I'm 100% you know it for sure, right? Epithelium, below that you have lamina propria, submucosa, muscularis propria, and serosa, right? So that's normal GI epithelium. When you take a normal GIT, layers, it's simple, perfect, right? Epithelium, submucosa, muscularis, serosa. Clear? Like Medico said, I have 4 layers. I have epithelium here, I have glands here, submucosa. Just for understanding, let's put a pink color muscularis, and I have a serosa, right? Can I say this is normal? Right? I have mucosa, I have submucosa, amazing. I have muscularis, I have serosa. Okay, perfect. Now tell me, who told my entire GIT? GIT is from oral cavity to anal canal, close to 8-9 meters long, right? So 8-9 meters long. I can see your chat, Karthik. You can comment on it. It's not recorded. I have an 8-9 meter long GIT. There should be someone to tell the entire GIT, see, mucosa should be on the top, serosa should be in the bottom. Someone should tell that. That's what polarity means. Throughout the layer of GIT, there will be mucosa on the top, submucosa, muscularis, serosa. This orderly maintenance is called as a polarity maintenance, and this is helped with the help of STK11. So the STK11 gene tells to my entire GIT, see, mucosa should be on the top, serosa should be in the bottom. Understood? Clear this? Till this? Right? Perfect. Now let's see when I have a mutation of STK11. Okay. If I'm having a mutation of STK11, I want you guys to answer. STK11 is a tumor suppressor gene, so you'll have gain of function mutation or loss of function mutation. We've been doing this for the past 2 genes. It's the same thing, right? Obviously, I'll have a loss of function mutation. So when I have a loss of function mutation in the STK11 gene, so can I say, perfect again, can I say the cell's polarity will not be maintained? Is that statement right? The normal function is to maintain polarity, right? It will not be maintained. Yes, science, I am from Tamil Nadu. You can ask once, that's enough. Okay, can I say it will not be maintained? It will not be maintained. Perfect. Okay, second question. So the function of normal STK11 is to reduce cell division. Can I say when there's a loss of function mutation, there is more cell division? Yes? Perfect. So when STK11 is lost, there is more cell division, and my body's, especially GIT, cannot maintain polarity, right? I'm just going to assume, can this happen? I'm going to assume one thing. I want you to tell if this is possible or not, right? Let's take in the GIT, I'm going to have more cell division, and then I'm going to have loss of polarity because of the mutation. So is it possible for me, let's assume this is my epithelium here, suddenly I have a projection here. Because of more cell division, it becomes big, and in this projection, is there a possibility the muscle can come on the top, till the top? Normally muscle should have been way below, but here, because of the loss of polarity, muscle comes to the top and goes between the epithelium. Is this possible? Not possible. Possible? Normally I have an epithelium which is perfectly aligned like this. That's what normally you have in GIT, right? Like this. Mucosa, submucosa, muscular, serosa. But here, because of loss of polarity, the muscle goes between the glands, and glands can come down as well. Possible? This is the classical appearance of a huge jigger polyp, right? So this is how the polyp looks like, and this is discovered by huge jigger, and he gave the name huge jigger's polyp. That's a classical thing, right? It's an arborizing polyp. It's an hamartoma. Good evening, Shweta. Yes, I'll have a mass. It'll form like a polyp, right? So in this pugiger polyp, the only finding is I'll have excess amounts of glands because I'm having more cell division. I'll obviously have excess amount of muscle because there's more cell division, but in a disorganized fashion. So you have something in disorganized fashion. That's actually the definition of hamartoma. Like Ankit said, that's what I call as an hamartoma. Excess normal tissue in the normal location, but in an abnormal fashion, which means muscle is going between the glands because of loss of polarity, right? Now, let's extrapolate one more important finding in a disease called as Peutz-Jeghers syndrome. Because Peutz-Jeghers, the mutation of STK11 can be inherited. Almost every tumor suppressor gene can be inherited. Fine. Okay. Fine. Ayush pharmacology classes will resume by April 1st, the next week onwards. Fine, don't worry about it. Okay. Now I'm going to ask you a simple question. Can I say GIT, oral cavity is a part of GIT? Yes. Rahul, I always believe that I should stick to what I'm comfortable with. I'm good in pathology, I'll teach that. We have Dr. Santosh, he is good in medicine, he will teach medicine. Right? Yes. Mouth is a part of GIT. From mouth to inner canal, the entire thing is GIT, right? Perfect. Now, let's take mouth. Can you tell me what is the normal lining of mouth or the oral cavity, oral mucosa? What is the normal lining epithelium? I want you guys to comment. It's a simple thing. Oral cavity, lips, buccal mucosa. What's epithelium? It is stratified squamous epithelium. Is that right? Oral cavity is made of stratified squamous epithelium only. Perfect. Right. So if you remember stratified squamous epithelium, it's going to be like this. Multiple layers of cells. That's what stratified squamous epithelium is. It is squamous only. Now, in the basal layer of squamous epithelium, there is a cell in the basal layer of squamous epithelium called as melanocytes. I am drawing it in black in color just for us to understand. I have melanocytes. Normally, melanocytes will be in the basal layer of epidermis. That's the normal location of it. And who told them to go to the basal layer? My STK11. My STK11 told, see, you are a melanocyte, you should be in the basal layer only, because that's maintaining the polarity of squamous epithelium, right? And the topmost layer will be keratin or stratum corneum. Fine. Now tell me, when I have an STK11 loss, is there a possibility I have a mutation in the STK11, I have an STK11 loss? Is there a possibility that these melanocytes can come to the top? Yes. Or can go to the dermis? Possible? They don't know where to go because I don't have STK11, which didn't exactly tell me to stay in the basal layer, because that's what told me you have to be in the basal layer. That's what told me about the polarity, right? So when STK11 is lost, there is altered polarity. When there's an altered polarity, obviously the melanocytes can go to anywhere. Okay, I'm just saying for an example, let's assume melanocytes went to the stratum corneum. Just for an example, I'm saying that it goes to the stratum corneum. When the melanocytes, that is melanin producing pigment, comes to the stratum corneum, the mucosa will become black or hyperpigmented or hypopigmented. Hyper or hypo? What do you think will happen? Hyper, hypo? You guys have to answer. It's a simple thing, right? Melanocytes coming to the top, obviously you'll have hyperpigmented patches. Because of this, you'll have a classical oral mucocutaneous hyperpigmentation. Okay, that's a very classical finding in case of an Peutz-Jeghers syndrome or a Peutz-Jeghers polyp, right? In Peutz-Jeghers syndrome, I'll have it. Karthik, it won't be hypo because they will go up because I don't have the polarity, right? No, Rahul, I just gave an example of it will go down. It will not go down because melanocytes location is in the skin. So the maximum bottom line they can go is stratum basal. They'll have to come up only. I just gave an example. It won't have the normal location. That's all. it automatically will go up, fine. They'll have oral mucocutaneous hyperpigmentation. That's also a classical finding seen in Peutz syndrome, fine. Okay, that's again about STK11. So whenever you read, you see, you guys are in very early part of your career, second year of MBBS. If you can develop interest in medicine now, it will stay forever. If you don't develop interest in medicine now, medicine will always be a burden, right? It's just simple things. Normal cell division and maintenance of polarity is lost throughout the body. Wherever it is lost, I'll have the same function, same outcome, right? So that's what happens in Peutz syndrome and STK11, right? So we saw about 3 more genes. I'll give you a homework. I want you to read. I gave homework for essential batch students. I hope you guys went through the patterns of neoplasia in the book. You can ping me on WhatsApp. Ankit, there the loss of polarity is there because cilia is lost in case of a polycystic disease. It's almost the same. The loss of polarity is almost the same here, but here it's a different use. There is a different use case, right? But loss of polarity concept is same, right? I want you guys to read neurofibromatosis. I want you guys to read von Hippel-Lindau, these 2 genes, and one more gene, APC gene. In Robbins, just half a one paragraph, maximum put together will be half a page, right? And I want you to comment on, reply to my WhatsApp or on Instagram or in Telegram, wherever you find me. I want you to reply a few questions. The gene of neurofibromatosis, 1. I want you to reply syndromes not now associated with your APC mutation, and also paraneoplastic syndrome due to VHL, right? These are 3 questions for you. Just read whenever it's possible from your Robbins and ping me, right? If there are any doubts in today's class, let me know. Otherwise, we'll call it a day. No doubts? Great. See you soon in the next class. Till then, bye-bye. Enjoy your weekend. Bye-bye.